Hello my dear doctors, welcome to the topic rheumatoid arthritis complications, Felty syndrome, FS. So the KBA lectures on this topic like the FS, that you will see that how this knowledge will be applied in a best way, and also the question based approach that we learn here. So let's talk on Felty syndrome and the rheumatoid arthritis complications. Before starting the rheumatoid arthritis complications and the Felty syndrome, let's flashback and recap what we learned from the video lectures. We learned from the video lectures complications of rheumatoid arthritis. You put a single mnemonic is a radio FM. So RADIO, radio, and FM, yes, F for Felty syndrome. And the complications of rheumatoid arthritis, once again, the Felty is the Felty syndrome. We put RA for rheumatoid arthritis, L for low WBC, and TY for splenomegaly. Yes, the RA, low WBC, and splenomegaly. So let's see how we can apply our knowledges into the terms and the question-based approach. According to this KBA or QBA, right, we need to read the first step, right? What is the cause of our neutropenia? So starting with the options like the Felty syndrome, penicillin-induced myelodysplasia, and MDS, and folate deficiency, and Hodgkin's lymphoma. So immediately after reading the options, the third step, think about the SS box that what we learned. We learned the Felty syndrome is the Felty syndrome. So we need to focus on the RA, L for once again the low WBC, and also T for the splenomegaly. So let's focus on to that. Immediately after the third step, the box that we need to focus on to the photograph, but the fourth step, the photograph is absent here. Next is the fifth step is the data. Data is the bottom line. Data is very much important. Bone marrow is hyperplastic. Hyperplastic bone marrow can be found in Felty syndrome. We learn. And MCV platelets is low, WBC low, and also the hemoglobin is low. So the pancytopenia, having the neutrophils, lymphocytes, and also eosinophil is high. So having Felty syndrome, what is the scenario? Said that on examination findings that she had been found the bilateral symmetrical deforming arthropathy, this rheumatoid nodules with ulcerated areas found over the shin. On an abdominal examination, spleen is found palpable 4 cm. Yes, the splenomegaly. So what we learned that rheumatoid arthritis, splenomegaly, as well as the low WBC counts. So yes, the Felty syndrome is a likely diagnosis. 67-year-old female, 21 years of rheumatoid arthritis. Noted to have the abdominal discomfort. She had to start the penicillamine for the last 6 years. So second differential diagnosis come up with the penicillamine-induced myelodysplasia, but the bone marrow study showed that hyperplastic, so how could it be? And other options like MDS, folate deficiency, and Hodgkin's lymphoma, we will discuss more. Let's now talk on some of the explanations. In patients with chronic rheumatoid arthritis, neutropenia, and splenomegaly, the most probable diagnosis, of course, the Felty syndrome. However, the other conditions studied the low WBC in rheumatoid arthritis, drugs like the GP, here's the methotrexate, and which are associated with the bone marrow aplasia. Folate deficiency can cause the pancytopenia. The bone marrow does not reveal the hypoplasia, therefore drug-induced myelodysplasia is unlikely here. The absence of megaloblast, once again, is against the diagnosis of folate deficiency. So in a bone marrow study, megaloblast, the Hodgkin's lymphoma may explain the splenomegaly and eosinophilia. Eosinophilia is well recognized in rheumatoid arthritis, particularly in patients with the skin vasculitis, pulmonary fibrosis, and subcutaneous nodules, and is less likely than the Felty syndrome, particularly as the disease would have to be fairly advanced to produce pancytopenia, as in this case. Furthermore, Yes, at such an advanced stage, we would want to expect the bone marrow to have a better yield of diagnosis than it normally has in the very early stages of Hodgkin's lymphoma. Myelodysplasia can cause the hypercellular bone marrow. So myelodysplasia, once again, hypercellular marrow with the peripheral eosinophilia, but splenomegaly is uncommon. So now let's talk on the SS box, and these SS boxes will be tremendous helpful. Let's see the rheumatoid arthritis with the neutropenia with the spleen. Of course, the Felty syndrome should be thought about first, considered first. So start with the rheumatoid arthritis, neutropenia and spleen. FS is a Felty syndrome, so we put a mnemonics of the FG, alright, A, B, C, D, E, F, alright, F, G, H, and small s. So what does it F for? Yes, the Felty syndrome. The most important finding is the bone marrow hyperplasia. And the F for folate deficiency, pancytopenia, of course the bone marrow hyperplasia, but the megaloblast. And once again, the rheumatoid arthritis with the WBC total will be reduced with the GP, G for gold and penicillamine, and MA for, once again, methotrexate, yes, and the azathioprine. So once again, my dear, what I'm saying, the F, G, G for GP, so in that case, the bone marrow hyperplasia is the findings. Hodgkin's lymphoma, the spleen and eosinophilia can be found, but pancytopenia in more advanced disease. Myelodysplastic syndrome, S for syndrome, alright. Bone marrow hyperplasia once again. And eosinophilia is raised, but the spleen is rare. So somebody talk of the rheumatoid arthritis of neutropenia, the spleen, the Felty syndrome, folate deficiency, G for gold, penicillamine, methotrexate, and azathioprine, and H for Hodgkin's, and S for syndrome. In all cases, right, the Felty syndrome as well as the, yes, in case of syndrome like the myelodysplastic syndrome, that we will get the hyperplasia, bone marrow hyperplasia, in contrast to the drug-induced cases that will get aplasia. And rheumatoid arthritis with eosinophilia is a very good combination. Usually rheumatoid arthritis, skin vasculitis, lung fibrosis, and also subcutaneous nodules. Now let's talk some SS box of the anemia in the rheumatoid arthritis. Anemia in rheumatoid arthritis, many causes can be found. So once again, just start with the FGH. Alright, once again, this is very important, FGH. So once again, F for once again the Felty syndrome we can put. And once again, the FS for fast spleen. Fast spleen with the hypersplenism leading to Raynaud's syndrome. Here's RA, low splenomegaly, and pancytopenia, bone marrow hyperplasia. Once again, the folate deficiency due to increased cell turnover in chronic inflammation leading to megaloblastic anemia. The findings of pancytopenia but bone marrow hyperplasia, but in megaloblast. GP, bone marrow suppression, pancytopenia, but with the bone marrow aplasia. So FGH, H for hemolysis, autoimmune hemolytic anemia, and autoimmune, and these associated with the autoimmune diseases like the pernicious anemia. And also the iron deficiency anemia because of due to NSAIDs, and also anemia of chronic disease. These two reasons can cause iron deficiency anemia. So somebody talk of causes of anemia in rheumatoid arthritis and FGHI. F for Felty syndrome, F for folate, G for GP, yes, once again, H for hemolysis, and I for iron deficiency anemia. But in contrast, the R with the neutropenia with the spleen, once again the FGHS. Next talk with the pancytopenia with the rheumatoid arthritis. Of course, that we start with the FG, means the Felty syndrome, and also GP. The investigation, the first of all, for the Felty syndrome, that we need to diagnostic test the red cell sequestration study, that RCSS, Royal College of Surgeons. Alright, so yes, this is the RCSS. That is the red cell sequestration study for Felty syndrome. The demonstrating increased red cell uptake and destruction by the spleen. And bone marrow, aspirate and trephine, can cause the bone marrow aplasia. In contrast, the hyperplasia in case of Felty syndrome. So two diagnostic tests in case of pancytopenia and rheumatoid arthritis. So it is said that often white blood cell count and differentials are crucial determining the degree of granulocyte. Studies showed that the greatest risk of infarction, the granulocyte count less than 1000. It must be kept in mind, however, that the level of neutropenia varies over time without medical intervention. Granulocyte dysfunction and absolute decrease in the number of granulocytes may predispose to infarction. Anemia and thrombocytopenia may result from hypersplenism. Yes, anemia and thrombocytopenia may result from hypersplenism. Anemia of chronic disease may result from underlying inflammatory disease. Mild elevation of alkaline phosphatase and transaminase may occur, and 98% of the Feltis syndrome are the high titers of, yes, rheumatoid factor. An extra-articular manifesting rheumatoid arthritis strongly associated with the rheumatoid factor and are found in 67% in histone antibody, even ANCA commonly occur in patients with Feltis syndrome. Significance of autoantibodies Feltis syndrome is unknown, and their contribution, if any, to the disease itself is uncertain. ESR, serum immunoglobulin levels are invariably elevated in patients with Feltis syndrome. Cryoglobulins may be present. Now, a short recap of Feltis syndrome with the classic triad risk factors and Feltis syndrome treatment is the DMRD methotrexate splenectomy. TNF alpha blocker no study in actual treatments of Feltis. Steroid improve the neutropenia but increase risk of infarctions. So treatment for the Feltis syndrome directed against the neutropenia. Most frequent no additional treatment for cytopenia, but DMR is the most important, the methotrexate. Yes, usually the drug of choice, often used to improve the cytopenia, cutaneous vasculitis, and also the infarctions. And then once again, that is the splenectomy is indicated recurrent serious infarctions resistant to DMRs. So we can make a box and note for the Feltis syndrome treatment, so that will be helpful, right? So Feltis syndrome treatment, we can write the F4 folate means methotrexate is the first line treatment, and S for splenectomy. So this is very helpful, my dear children, regarding the treatment. So Feltis syndrome treatment is once again folate and methotrexate, and as well as the S for splenectomy. Feltis syndrome is a classic triad manifestations, the non-healing leg ulcers, you see, the infections, common cause of death. Important differential diagnosis, the large granular lymphocyte syndrome. So we can call the LGL syndrome. Many circulating large granular lymphocyte, neutrophil, and splenomegaly and frequent infections are probably cytotoxic T cells or natural killer cells are large granular lymphocytes. Unlike Feltis, the 3 to 14% of the patients with LGL progress to leukemia. So exacerbations rather than improvement frequently follows the splenectomy. So no splenectomy. Immunophenotypic surface marker not typically seen with the Feltis. That is CD2, 3, 8, 16. Variant of Feltis is a peripheral blood or bone marrow is the LGL cells. LGL cell is a large granular lymphocyte. So the large lymphocytes having some of the granules. So peripheral blood smear from a patient with a T cell, large granular lymphocyte leukemia shows 4 large granular lymphocytes. Yes. 15 to 18 microns in size, about twice the size of the red cells, abundant cytoplasm containing the typical azurophilic granules and around to oval nucleus. So 3 to 14% cases, large granular lymphocyte can leukemia, unlike Feltis. So LGL, yes, once again, is another syndrome, is a variant of Feltis. The differentiating features, the LGL cells is present. So what is the cause for a neutropenia? Of course, the Feltis syndrome is a likely diagnosis. So as we have seen, we can go back to the question scenarios. As you have seen, right, the bone marrow hyperplastic is only found in the Feltis syndrome. Is a very good diagnostic fellows of the Feltis syndrome. But the penicillin is aplasia. Myelodysplastic can have the hyperplasia but the myelodysplasia will be present, as well as the folate deficiency will have the megaloblast in the bone marrow. Now let's talk on another questions. So according to the question approach, right, best approach, that we'll start with the main question. What is the most likely possibility of his presentation? Septicemia due to respiratory infection in methotrexate-induced neutropenia, azathioprine-induced neutropenia, Felty syndrome-induced neutropenia, acute hepatitis due to methotrexate, acute hepatitis due to azathioprine. So we have understood the patient have the significant neutropenia. So what is the underlying reason of this neutropenia? So according to the question approach, after the second step of studying the answer options, that the SS box that we need to remember, so immediately after the photography is present, if not photography, then data, and data is a down to up. Data down to up is the albumin is low, alkaline phosphatase is raised, AST is raised, serum bilirubin is raised. So yes, this is an hepatitis. We can say the raised bilirubin with the AST alkaline phosphatase is raised. So once again, the hepatitis. And creatinine and urea is normal, potassium, sodium normal, but the CRP very significantly high, and 68 is an ESR, INR slightly raised. Reticulocyte normal, MCV high, platelet low, WBC low, and hemoglobin low. So once again, this is a pancytopenia. Yes, pancytopenia with the macrocytosis. That is very important. That can be done by the methotrexate, and also can be done by the azathioprine as well by the next diagnosis. But the pancytopenia with the macrocytosis, with the raised inflammatory markers, with the hepatitis, can be caused by methotrexate. Because the rule of methotrexate that we learn another lectures, right, that will see that the methotrexate rule of M, my dear, M for mucositis, mouth ulcers, and myelosuppressions. They can cause the pancytopenia, and also MCV is raised. So myelosuppression leads to pancytopenia and MCV raised, along with the liver and lungs. So liver is involved, and we'll see the lungs. Yes, here is a septicemia due to the neutropenia, means the methotrexate induced neutropenia. Now we'll see the examination findings. The one examination was unwell. Alright, the jaundiced had a temperature. Jaundiced, temperature like. Yes, the examination of the oral cavity revealed the candidal infection in palatal. So having a candidal infection in palatal pedichy, on auscultation of the lung piece, there was a coarse crackles of the lung, right lung base. On abdominal examination, there was evidence of palpable spleen of 4 cm below the costal margin. Over the 18 months, 47-year-old male history, rheumatoid arthritis, cough, high fever, and painless jaundice. He had a 7-year history of the rheumatoid arthritis, affecting his shoulder, elbows, and wrists and joints, which was refractory to therapy with the NSAIDs. 18-month symptom had progressed. He switched to the immunosuppressive drugs, and which had controlled his symptoms. He was non-smoker and consumed less than 2 units of alcohol. So for the 18 months, right, he had been switched to the immunosuppressant drugs. So there is also a possibility of the Felty syndrome, because the splenomegaly, once again, with the pancytopenia that we learned, the raltis, rheumatoid arthritis, low WBC, and splenomegaly. So another possibility of the Felty syndrome. But why this hepatitis cannot describe the Felty syndrome? What is the first investigation that you should do? Yes, of course, if it is the methotrexate or whatever, the azathioprine or Felty syndrome can cause the neutropenia, so that should be the septic screen. After stopping the methotrexate-azathioprine, what will be the next best step of the management? Of course, starting the broad-spectrum antibiotics first. Now let's talk some of the explanations. These patients with rheumatoid arthritis, with the respiratory tract infections and high fever, blood tests reveal the profound neutropenia, which has almost certainly predisposed him to the respiratory and oral candidal infections. In contrast to the rheumatoid arthritis, neutropenia is either drug-induced or secondary to hypersplenism, major Felt syndrome. Felt syndrome alone cannot explain the abnormal bilirubin alkaline phosphatase, which in the absence of abdominal pain suggests either a cholestatic hepatitis or cirrhosis of the liver. But both methotrexate and azathioprine, which are sometimes used in immunosuppressants in rheumatoid arthritis, may also cause the hepatitis and cirrhosis. The mode of action of these drugs is to interfere with the purine nucleoside synthesis required for the nucleic acid generation. All cells in the body rapid turnover time are affected, particularly the cells in the marrow, hence the pancytopenia. The raised MCV is probably megaloblastic anemia, but may be due to the chronic liver disease. And having a megaloblastic anemia due to methotrexate or azathioprine, megaloblastic anemia due to folate deficiency, megaloblastic anemia due to folate deficiency due to methotrexate, and also the liver cirrhosis can cause the raised MCV. Methotrexate-induced liver cirrhosis only comprises 1% of all patients taking the drug. Liver disease is more common in patients consuming over 10 units of alcohol per week, patients with diabetes, patients taking the drug frequently. In the early stages, the symptoms are non-specific and comprise anorexia and nausea. However, the late disease presents with the portal hypertension and varices or hepatocellular pictures or failure. Azathioprine-induced hepatitis is rare but may occur early in patients taking the allopurinol, as the later drug potentiates the effects of azathioprine. Azathioprine-allopurinol drug interaction increase the potentiations. So among the talk of MTX, means the methotrexate, azathioprine, and third is the Felt syndrome. Top of the list the methotrexate-induced. The neutropenia leading to septicemia, leading to respiratory tract infection. So that is the most likely diagnosis here after having such an explanation. So let's talk on rheumatoid arthritis neutropenia. The first, the Felt syndrome. LFT usually not Dylan occurs, means the hepatitis not occur, but drug-induced MTX and azathioprine, they can produce hepatitis, raised MCV, and also megaloblastic anemia. Both can produce. Investigation should be done in this case, of course, the chest X-ray for respiratory infection, oxygen saturation, septic screen, and ultrasound hepatobiliary system because of the raised alkaline phosphatase, to exclude any extrabiliary obstructions. So immediate management of this patient is the septic screen and followed by the broad spectrum antibiotics. So the stop the immunosuppressant drug broad spectrum antibiotics should be started. Usually the combination of penicillin and aminoglycosides, and third line cephalosporin. Be careful when performing the blood gases in patients with low platelets, abnormal clotting. Oxygen saturation should using for the pulse oximeter rather than doing the arterial blood gas analysis. An ultrasound scan of the biliary system should be requested to exclude the biliary obstruction. So the summary talk, what is the most likely possibility? There is an MTX-induced neutropenia leading to respiratory infection, leading to septicemia. What is the first investigation you do? The septic screen. And after stopping the methotrexate and azathioprine, what will be starting broad spectrum antibiotics? Here's a quick recap of the summary box of the radio FM royalties, as well as the rheumatoid arthritis neutropenia with the spleen is FSGS, and also the anemia and rheumatoid arthritis at FGHI, and pancytopenia rheumatoid arthritis diagnostic test for Felt syndrome with the restless sequestration, syndrome sequestration study, and also the bone marrow study. And Felt syndrome is a treatment, once again, for folate, the first line, and also MTX and splenectomy. Then LGL, once again, is a LGL cells in the peripheral blood, but no splenectomy. I hope that, my dear, the talk that we learned here, along with the Felty syndrome, usually don't affect the liver functions, but the drug induced like the MTX and azathioprine both can cause the hepatitis and cirrhosis and MCV and also the megaloblastic anemia. We can go back to the scenarios, right? In the scenarios, we can remember that the patient having the pancytopenia, the macrocytosis with the raised INR and also the albumin low. So this is involving basically the chronic liver disease, maybe some of the acute insult, AST and bilirubin is raised, but having also alkaline phosphatase, that is also ultrasound should be done, maybe associated with cholestatic pictures, presence or not. We will discuss about the liver function test and also the interpretation of the liver function test altogether in the chapter of hepatobiliary system, my dear. So you'll learn them what I said, very, very differentiating features that we can understand. I hope that, my dear, the boxes that we learned for the Felty syndrome, that will be really, really helpful. So thank you very much, my dear. Thank you once again.